friends, welcome to English Shorthand class. Ready? 1, 2, 3, start. Urban slums and neighborhoods where socially disadvantaged caste and community groups and migrants from Adivasi communities often reside have poor access to and low levels of trust in the healthcare system. Vaccines should be provided in camps or door to door in such areas. Appropriately, local governments are considering providing vaccines to older adults in door to door campaigns. A similar approach vaccination camps where they live. In India today, perhaps the most marginalized are religious minorities and specifically poor Muslim communities. Vaccine distribution should also be prioritized to Muslim dominated Tier 3 towns across the country. An explicit focus on justice would prioritize the engagement of trusted spokespeople to engage in effective risk communication with vulnerable and marginalized communities and to build trust in the vaccine. Women only vaccine days. We need women only vaccine days to ensure that women know that they are being prioritized. During the 1918 influenza pandemic, India was one of few locations where mortality was higher in women than in men, and we barely understand the drivers of this observation. In the current pandemic, it is very possible that if women are not explicitly prioritized, economic pressures to protect the breadwinner in families and the historically marginalized nature of women in society will end up resulting in gender inequities in vaccine uptake. Early signs of exactly this have been recently reported. Unfortunately, our data during the pandemic do not allow us to examine whether gender, caste, religious, and indigenous identities have impacted the risk of SARS-CoV vaccine to infection or death. Despite global calls for better surveillance, including among vulnerable groups, India does not regularly report even gender disaggregated data. Despite crowd-sourced efforts to collect and make data available, reporting of geographic and other metadata for tests conducted and sequenced samples is variable across laboratories and states. Better leadership to standardize and enforce metadata collection and timely reporting is essential to inform data-driven interventions and prioritized resource mobilization. Equity and justice. Local planning will need to go hand in hand with a refocus on equity and justice at the national and global levels as well. Nationally, people have recognized that digital apps for registration are a recipe for inequity along age gender, and economic dimensions, and reports have highlighted the plight of those on the wrong side of the digital divide. COVID data that are available to data show that vaccination rates have been inequitable between tribal and non-tribal areas. For example, going forward, let us focus on first doing no harm, get people vaccinated to save the lives most at risk. At the national level, the recent decision to procure vaccines centrally and make COVID-19 vaccines available free of cost through the public system goes a long way towards ensuring equity and justice. WHO has been tireless in its call for the urgent need for vaccine equity at the global level. In an ideal world, vaccines would be procured and equitably distributed to countries based on need through the COVAX facility. But instead, wealthy countries have once again, as during the 2009 H1N1 flu pandemic, secured more doses than they need to vaccinate every member of their population and even pre-ordered booster doses. This leaves only poor countries to be dependent on supplies through COVAX, and they find themselves at the end of the line. This is a wake-up call for setting up vaccine distribution systems with equity in mind for the next pandemic. At this time, unfortunately, poor countries are at the mercy of the European Union and the United States, who need to donate vaccines now. They need to vaccinate the world alongside their own communities. They need to vaccinate grandparents everywhere alongside children and adolescents within their borders. Work during the 2009 H1N1 flu pandemic showed that willingness among the US public to donate vaccines to the poorer countries was appreciable. Today as well, surveys show that US public support for immediate donation of COVID-19 vaccine exists. Doses need to be donated to COVAX now so that they can be distributed to countries based on need. Every life matters in this world, and world leaders need to follow the lead of WHO and embody global solidarity in this pandemic. Refocused, rejuvenated local, national, and global vaccination campaigns are possible. Let us ensure that we plan now so that we get those shots in arms when they are available. Let us get to work in India.